So our next speaker is Dr. Susan Coote, who's a senior lecturer in physiotherapy in UL. Having gained clinical experience, she undertook her PhD in Trinity in stroke rehabilitation, and she's extended her theme of technology and healthcare into her current research, focusing on multiple sclerosis and particularly on falls prevention. Her excellence in both research and teaching has been recognised in UL, and we look forward to her presentation on embedding research into clinical practice, a health profession's perspective.
Thank you very much for that introduction, and thank you for the invitation to speak here. I'd like to congratulate the Irish Health Research Forum on another really good, thought-provoking agenda that hopefully will stimulate lots of discussion. I was invited by Professor Martin O'Donnell to speak, to give particularly an allied health professions perspective and an early career researcher perspective. I think particularly we talked about multidisciplinarity. We know that the health system works within teams, so I think it's particularly encouraging to see the forum moving beyond the medical professionals and thinking about the therapies and how we contribute to that. I also like that I'm still an early career researcher because it makes me feel much younger than I actually am. And it reminds me that although I've done a lot, there's still lots more to do. So thank you on both of those counts. So as Jerry mentioned, I'm a senior lecturer in physiotherapy. I am in the University of Limerick. I've been there for 12 years now. I started when the School of Physiotherapy opened first in UL. And as I said, I'm going to give a very contrasting presentation to Janet's, in that I'm going to do a kind of a reality check on the ground in preparing for this. I've obviously used my own career development. I've talked to other clinicians and academic staff in our building. That's physiotherapy, occupational therapy, speech and language therapy, and nursing. And I knocked on lots of doors and said, well, what would make it easier for you to be a researcher? So I asked that question of many different people to get here today. Just very briefly to tell you a little bit about my career that I'm going to draw on. I think I did everything the wrong way round. I went to America to a very well-paid clinical job where I had lots of mentorship, lots of very clear career structure. I came back to Ireland. I started in Telehospital the day it opened as a neutral, which was the best place to be on that day, and worked as a senior in the stroke unit there and in the neurology department. And I then went back, so having taken a fairly major pay cut then, I then took a fairly huge pay cut to come back to be a researcher and PhD student at Trinity. And then when I was finishing up, in the position that, and I think this is one of the challenges I'm going to talk a lot about in the next 20 minutes or so, I ended up in an academic job, setting up a clinical placement structure while trying to become a researcher, having had no postdoctoral training experience. So I think it's interesting, Janet talking about research careers, and I would argue that at the moment we possibly don't have research careers in Ireland. I think we have PhD researchers and we have academics and we have clinicians, but I'm not sure that we've got the bit in the middle right in order to create the career structure that's there. So I'm now an active researcher in the field of MS. I lead the MS research group at UL. I've brought in nearly €1 million funding. I graduate lots of PhD students. I do publish in high-impact paper journals. And so it's really just about kind of talking to you about my journey and how I've got here. And I think we have to give some context to the therapies and to the health service. So when I started my PhD in 2001, there was only 6 people with PhDs, physiotherapists with PhDs in Ireland. Nobody could actually tell me how many we have now, which I think is interesting from both the professional bodies and the universities. But we know we've graduated about 10 PhDs in physiotherapy in Limerick, and Trinity have graduated about 18. So we're still, as professions, we're very much in our infancy. But despite that, we are relatively hard-hitting in our international reputations. You will see lots of people presenting at international conferences, getting individual awards. The president of the World Congress of Physiotherapy is now a physiotherapist, Emma Stokes, from Trinity College in Dublin. We certainly punch our weight above our weight in terms of heads of population, in terms of the number of research publications we're presenting. So I think as professions and the other therapies are in hot pursuit of physiotherapy, we certainly have huge potential to become leaders in research that influences both the academic and the clinical settings. And I'm going to draw on both the academic and clinical settings in my presentation. So as I said, I knocked on a lot of doors. I asked people about what would help them what would make their job as researchers be easier. And of course, everybody said time and funding, but that's an easy way out. So I didn't let them stop there. I said, right, well, what would you do with that time? What would the funding do? What could we go on to do? And I guess these are the kind of 5 themes that I'm going to talk around. The post-PhD void, so what happens after your initial training process as a PhD. Access to leadership and mentorship, and I think that reflects where the professions are and possibly where health research in Ireland is in terms of leaders and mentors. Thinking about research infrastructure and networks, which again is a recurrent theme, I think, across health research in Ireland. And then thinking about not only the academic careers that Janet has talked about, but really how, if we're talking about health research has to be originate from and be embedded in clinical practice, because ultimately we want to change the health service and how health service is delivered. And then thinking about career structures. So this is a black hole, and this is what people talk about when I ask them so this was the biggest issue for everybody I talked about, that post-PhD void, that black hole that people fall into. For academics, it's a black hole filled with teaching and service, and teaching gets scheduled and students turn up, and so teaching happens. And research is kind of the thing that you do on top of that, as opposed to the thing that is embedded within a career structure. For clinicians, we've had some very good success in UL with what were then the Therapy Professions Fellowships, which are now the Clinician Scientist Fellowships. And again, those people either return back into their early academic career, or they go back into the health service, into a health service that doesn't necessarily value them. So they go back into basic grade positions. They go back into dealing with waiting lists and managers who don't prioritize research, despite the fact that they clearly have the skills that could contribute so greatly to the development of the service they're working in. So we have one postdoc across our academic department, and I think this is reflected across other disciplines, that really postdoc positions are not readily available. It's very hard to talk to people who are graduating with PhDs who could go back into clinical practice and earn a significant salary, and try to persuade them to take a very small IRC postdoctoral fellowship. It's a very hard conversation to have. It might be better for their career, but they really don't want to do that because they don't see the value in it. They're continuing on a very low salary when they could be earning more other places. I think researching clinician positions are that we need to think about, and not just fellowships and early career training fellowships, but thinking about how we support clinicians as researchers in the future, how we create those academic links. And I think, personally, for me, I'm going to take the opportunity to say what my biggest desire is at the minute. As I look at my counterparts in the US, who, when they apply for health service, for health research funding, part of that research grant buys part of their own salary. So I currently am running a large multi-center randomized control trial. I do that on top of the same teaching allocation and admin allocation as everybody else. So it's seen as an add-in for me. So for me, as an early career researcher with hopefully lots of potential to develop, it's very hard. It's again, that work-life balance, that lack of life balance in terms of juggling everything on top of this teaching that gets scheduled. So I think academic buyout, I think, is a very important piece that we don't have in terms of health research funding in Ireland. And the other thing that people in their early career talked about was they kind of get dropped into this without knowing where to go next. And they talked a lot about needing training to help them to apply for grants as PIs. So they have their PhD training, they write lots of very good first author, last author publications. They're supervising PhD students, but they need support to get to that next stage, to write those grants as independent PIs. So the next piece is leadership and mentorship, and this may be very unique to the therapy professions, but I don't think it is. I think we need both leadership in the academic sector, but also in the clinical sector. People talked a lot about their consultants, and if you happen to have a consultant who is very pro-research and helps provide the leadership in that direction, research is much easier than not. It's quite hard for people to find patients. I think, again, in terms of clinical leadership, I'll talk a little bit later about career structures, but we created these pathways. So typically, basic grade physiotherapist, senior physiotherapist, and then you go into management. And we started to create these career structures where we had clinical specialists that were meant to have a research role, but then where did they go? And the reality is they go back into management too. So we never developed on those clinical specialist roles to allow those researching clinicians to develop and have a career structure. So I think that's something that is important. Professor Finucane is going to talk after coffee in terms of co-location and how that might works. But I think I'm thinking about actually being in the same building as people and being in a clinical environment doing research as an academic and vice versa, and how we can work that. We very much welcome the HRB Research Leaders Awards. I think they have been extremely useful. We hope that they will continue, and we hope that we will be able to extend them to look beyond the professions that have them now, to look at allied health professions as research leaders. And I guess part of this again comes back to my plea for help with my balance, academic workload balance, but enable leaders to lead. I think we have very significant leadership potential within Ireland. We have people who are presenting keynote lectures at international conferences on the topics that they research in. But we need to create structures both in the academic and the clinical setting that enable them to lead, that give them the support to be leaders and be the leaders that they can, to bring everybody else with them in terms of excellence. I walked into our research staff office, and it was really interesting because the first thing they said was ethics. And this is a really interesting thing. It's actually easier to get ethics for a clinical trial of a medicinal product that's very high risk than it is to do an exercise trial, which probably has a 2% incidence of adverse effects like muscle damage. So for me, in running my randomized controlled trial, I had to go to 5 individual committees with 5 individual ethics applications. 4 of them, luckily, the form looked mostly similar. But it's hard to do non-drug research in Ireland at the moment. The hoops you have to jump through. We have a lovely clinical network that I work with. We had to go to 10 sites for that trial. So again, there's pieces about ethics that would make it much easier to be a researcher and be a non-drug health researcher in Ireland. I talked a little bit about access to patients, and I think part of the academic clinical networks will support that. But I think the other issue in terms of patients and data is databases. We don't have good databases of patients. We don't have patient registries. So for example, if I was an MS researcher in the States, I can go to the NARCOMS registry, access about 10,000 people with MS, a range of different variables, and ask my question of that at a very low cost way of doing that because the database is there. We don't even know how many people have MS in Ireland at the moment, let alone where they go, who they see, what they're doing, whether they have a health record. We were talking a little bit over breakfast about the unique health identifiers. I think that's going to be a step in the start of this journey. But again, we can learn so much from big data. The TILDA database, for example, has been an excellent resource, but we need more of that, and we need to extend it into other disease categories or patient populations. We've come a long way in terms of clinical research facilities. Where I'm flying the flag for Limerick. We don't have a clinical research facility. We would love to have one. I think that, or if not, have a very strategic access to one. People talked about trials units, biostatistics, health economics. We've been talking about this in Ireland for a long time. I'm not going to expand on that, but there's still a need to develop. But even just as a researcher, I work, the clinical research facility in Galway is one of my partners. The creation of entities that can manage databases is great, but in the 20 odd months of my HRB grant, we haven't had access to the database more than we have, and that's a significant limiting factor. So it's great that they're there, but we have a lot more to do. The interface between the HSE data systems and the university's data systems is one of those blocks, so it's an example of how we can get better. And one of the other things that people would like is more opportunities to travel to other research groups. And I also am a fan of mobility. I had the opportunity to go on sabbatical and work in the States and in the UK. And I think the learning from that was huge. I still continue to pull on that. And I think until we show people what it's like to work in other places and what is expected, and I would love some people in my department to go and work in the University of Illinois just for a week to get some sense of how easy they have it here in a lot of ways, and just to show how competitive a research career is and how it can be. So I would love to see opportunities for people during their PhD training process. I know it's a feature of those fellowships, but I think as early career researchers, how can we enable people to travel and to get more exposure to other ways of working and other entities. So research networks are obviously important. Multidisciplinary research with a range of disciplines is the way forward, clearly. And again, we welcome the clinical trials research networks, but I think we have to remember that other networks that require relatively little funding can have a huge impact. I want to give two examples. So the PIMS here, it's not the alcoholic drink. It's also not the French biscuit that you see in the airports on your way home. It's physiotherapists interested in MS, and I have a network of 70 clinicians who join. There's no fee to join. That you just send me your email, and we work together. We send out articles around best practice. We send out research calls. We notify people of events. We organise our events ourselves. So MS Ireland recently had their Health Professions Research Day. But the PIMS group, we're using an Irish Research Council New Foundations grant at the moment to do a multi-centre trial to look at measures pre and post physiotherapy. So each clinician, with my support, is collecting 10 sets of data at 10 sites. Suddenly you have a data set of 100 a database of 100 people that you can then answer big questions. It's not big, it's quite small, but I think as we develop the big things, we need to remember that the small things can have impact as well. Another example is my colleague, Karen McCreesh, who was a HRB Research Fellow. As part of the KEDS grant, the Knowledge Exchange and Dissemination funding, she developed her shoulder community of practice. And again, she has a clinical network of clinicians, physiotherapists who treat shoulder injuries, rotator cuff tears, that are working together to do relatively low-cost, based in clinical practice research that is having a huge impact on the practice of those therapists that is part of the network, but also in terms of generating evidence to inform other people outside of the network. Special interest groups have been around for a long time, but again, special interest groups have typically been around clinical practice. I think they could be used a lot more as a research vehicle, as a way of enabling people to work together. I think this is probably my second biggest issue. It fitted better here. I probably would have liked to put it first. I have 2 PhD graduates who are working as basic grade physiotherapists. Because when after 4 years, delivering interventions, assessing the effect of interventions, developing, learning all of those transferable skills you learn as a PhD graduate, they were not eligible to apply for senior therapist positions in the HSE. And I think that's not good enough. We have to recognise that researchers are a valuable addition to the health service. I talked about salaries, so it's much more attractive to be a clinician than it is to be a researcher when you've finished your PhD. And that's something we need to do something about, as well as creating those posts in the first instance. I think the idea of creating research clinician posts is a good one. So again, thinking about what we do with those clinical specialists who are meant to have a research remit to their clinical caseload. Well, first of all, let's make sure that they have that, but then let's create some kind of a structure for them to move on. And just as an example, we have used some funding from MS Ireland to buy out a clinician from her clinical post. So we've used the funding, a student stipend, for her to be 2 days full-time research and the rest clinical practice. Now the impact for her obviously is she's getting that PhD training, she's getting all of that, she's working with the clinicians on the ground in collecting data. But the knock-on effect to her department has been huge. I met with her manager last week just to update her and let her know, and she was saying having somebody who's actively researching in the department that can help people critically praise articles, contribute to journal clubs, analyse data that's similar to hers has been an incredibly good thing for the department as such. So I think, again, enabling clinicians to be researchers as well, and enabling our PhD graduates to go back into clinical practice and continue to be researchers is very important to do. So how do we So we know that in theory we have an academic structure that allows people to move into academia. I would argue that we don't right now, in that we don't have that post-PhD research career piece. We don't have the opportunity for those jobs. We need to create more of them. But I think possibly the more exciting way to look at it is, and again, so that one of the biggest issues with health research is the lack of translation to practice, is the lack of implementation. So by embedding research and clinical practice together from the get-go, initiating the ideas in clinical practice, involving the clinicians and being part of the research team, we know that implementation and translation is much more effective. So how can we redefine those clinical specialist roles? How can we provide career progression for those clinical specialists? So that we create research clinicians. Again, we have fellowships that allow clinicians to do their PhD, but then what happens to them afterwards? Where do they go? And I've said this already, but that sense of practice informing research and research informing practice is ultimately where we want to be, that we can embed the findings of all this good research into practice. So hopefully that's given you some food for thought and maybe a little bit of a reality check. I think it is very definitely an early career therapy for professions bias, but that's what I was asked to do. But hopefully it gives you a little bit of a reality check. And just thinking about, well, what can we do about that black hole post-PhD? How can we enable leaders to lead and create new leaders? How can we create networks, both the big clinical trial stuff, but also the lower level stuff that actually might be the bit that has a greater impact on practice? How do we value researchers and clinicians? I think it's unacceptable that PhD graduates are working as basic grade therapists in the healthcare system. And how do we not only create careers for academics like me to be researchers, but how do we enable clinicians to be researchers, and how do we create those networks that enable clinicians and academics to work together, because ultimately working together is where we're going to get further by. Thank you very much.
Thanks very much, Susan. Very interesting perspective and stimulating talk. We have time for a few questions before coffee, if anybody would like to hear, and then so you just introduce yourself, please.
Eilish McCall of Health Systems UCD. Very interesting presentation. I suppose I'm struck by your comments about clinical specialists and redefining the role of clinical specialists. And I may be wrong about the therapies, but I know certainly for advanced nurse practitioners and clinical nurse specialists, it is within their role at the moment that they conduct research. So surely then it's a performance management issue rather than redefining the role, or perhaps the value the organisation places on research. But as I understand it, all those roles are meant to have a research remit.
And you hit the nail on the head, meant to have. So it's in the job description quite clearly, but the reality is that their research time is not protected. And I think it's about, I mean, a lot of people would say that my manager doesn't let me do research. So I think it's at that level that we need to target. So again, that enabling the clinical specialists to do research for 50% of their time, which is what the jobs were created to do. The reality is that if you ask most clinical specialist therapists in Ireland, they will say quite freely that they don't have that time for research, that their time is spent clearing waiting lists and being involved in clinical practice. So meant to have, yes. Whether it's implemented or not, I think, is the other question. And again, but why go into a clinical specialist role? Because it's a dead end. So where do you go next? How do you progress? And I think that the career pathway is such that you go into clinical specialist and then you come back out into management. So again, that's not valuing research outputs either. So in order to get a manager job, you need to be doing different skill sets than you would be developing if you were going to be a researcher. But, yeah.
We do have that challenge in terms of people who have a lot of expertise in clinical aspects and who then come on to train in doctoral programs. Where do you place them, and is it attractive enough for them to stay in those sorts of careers? I think a lot of good changes have come about between 2006 and 2015. But still the apex, as described in the briefing paper, still has room for 2 more roles. At the minute, it takes a research career up to a senior research fellow, but if you look at other jurisdictions like Australia, they've created 2 more categories in terms of pathways towards leadership, going beyond the senior research fellow to a principal research fellow and a senior principal research fellow. And they are in the same line as a lecturer, senior lecturer, associate professor, and a professor. And what's unique about that pathway is also that they pegged the salaries quite the same as the academic appointees. So you have the opportunity for those of the 10% of the 60 who aspire to stay in research careers, the pathway to stay. And I think one thing we are discounting in this conversation is that most people who do go on to do PhDs, you could give them the notional thought that they are bright and smart. They're not silly to think that everybody who get out of the program will stay in academic careers. So giving that top apex a bit more space and also taking on the discussion around FTWA is probably a good pathway to consider. Thank you.
Okay, I think that was more a comment than a question. Do you have any final question before we break? Okay, yes.
Thanks. Evelyn Mulroe, now from iCorg. Susan, thanks very much for your presentation, and I just wanted to pick up on the point you made about the connectivity between data within academic institutions and within the HSE. And we also see it within hospitals. And what we're doing in iCorg in the context of research, you know, we'd like to connect patients who are on trials with patients who are going through the health system and look at survival data and look at what it means. So it's like Groundhog Day. I mean, I started talking about this 8 years ago, and when it was the health information bill, and I know we have the unique patient identifiers, but we're a little bit away from what we want. So I'd love your comments on that and what we should do as a community to drive that agenda.
Yeah. I don't think I know how to fix that one. I think, as you said, if it was an easy solution, we would have done it until now. I suppose what I see is the value that is gained from data mining big data sets, and in terms of it being, in terms of cost effectiveness, I don't know, but in terms of funding a big research project to collect the data as opposed to collecting it on an ongoing basis and then looking at it retrospectively, I think there's obviously huge advantages to be done. We're looking forward to hearing what Marcia Connell is going to do in the Department of Health and in his new role. He started yesterday, so I'm not going to dump him in it right now. But I think hopefully this is part of your remit within the Health Department of Health. So hopefully that's a first step in solving that. But, yeah.
Okay, so I'd like to again thank Susan very much for her contribution. I think it's been very welcome and thought stimulating. So thanks.